Good morning, everyone. Thank you for joining us for our monthly endovascular live case webcast from Mount Sinai Hospital, New York. I'm Karthik Guja, your moderator today. We have David Song as our virtual moderator. If you guys have any questions, he'll be very happy to answer your questions. Before we move on to the cath lab for Dr. Krishnan, Dr. Kapoor, and Dr. Rao's team, just want to let you know about our NYEVS, which is coming up in September 24 to 26. We have international faculty who join us, um, giving their expertise and experience and talking about their cases they have done in the newest advances in the endovascular space. We would love for all to join us here in New York. And also we have a great fellows course arranged for fellows all over the world. If anybody is interested, we offer them fellowships to come in to attend the endovascular fellows course. So please do reach out to us. And then without any further delay, we'll move on to the cath lab to Dr. Krishnan, Dr. Kapoor, and Dr. Rao. Good morning.
Good morning, Karthik. Good morning, David. Thanks so much for doing this, both of you, especially David from the virtual side. Thank you.
Good morning.
I want to welcome everybody to the Cath Lab. As you know, our team is a consistent team. We've got Dr. Jit Rao, who's the director of vascular research, as well as an associate professor of vascular surgery at Mount Sinai Hospital. And then he also runs the simulation center for the vascular surgery team, in which obviously he does aortic simulation for the fellows, as well as numerous teaching courses. To my right is Dr. Vishal Kapoor. He's the director of Mount Sinai Morningside, as everyone knows. Ray Lascano, who has been part of every live case since we've been done it. And this year, for the first time, we've got not for the first time, for the, I guess, 11th or 12th time, we've got the new endovascular fellows. And it's a pleasure to welcome Vaishnavi Gadela. She's here for a year of endovascular training with all of us, including Dr. Rao. And she's part of a team of 4 fellows this year, which has definitely grown as our combination with vascular surgery, and everything continues to grow. Couple of things, just shopkeeping notes beyond what Dr. Gu just said. We are continuing the aortic endovascular fellows course, which Dr. Rao will talk a little bit about in a second, for the aortic fellows who are really particularly focused on aortic and want to learn aortic. It's fantastic. But before we get to Dr. Rao, I do want to say we have four industry-based therapy-based learning courses. And this is phenomenal for those of you who are watching, because if you want to come to NYEVS, you'd like to focus on a certain therapy. So for instance, we have renal denervation, which is run by Medtronic. It'll be a different faculty than NYEVS, but it's a one-day course on Thursday, the 24th, right, Vishal? Or
Yes,
25th?
24th.
And that is, slots are open for 20 people to come. You can go to the NYEVS website, and you'll have a therapy-based learning icon. You can press it. Obviously, it's industry-sponsored, so your hotel and airfare and all that will be taken care of by industry. Second is the IVUS learning course, which again is going to be sponsored by Philips, obviously focusing on IVUS and all things IVUS. Third is the Medtronic thrombectomy course, which is sponsored by Medtronic. And last but not least is the Boston Scientific. It's a combination course, but it's separated into 2 courses. One is for thrombectomy, and the other is for one is for IVL with the Bolt, and the other is for the TCAR with Medtronic. So, with the Boston Scientific. So ample opportunities for you guys to attend, and especially come as part of industry guests. So, Jit, you want to talk a little bit about the aortic fellows?
Yeah, I'm very excited about the aortic program this year. I think every year we refine it a little bit more. So this year it's going to be case-based talks. So we're bringing in really experts from around the country to showcase, some of the advanced cases they're doing in aortic, from infrarenal to thoracoabdominal aneurysms. So that will be the morning, and then in the afternoon we have a simulation program and a competition on our aortic simulators. So it's an all-day program. There's always a wide range of faculty, trainees, and it's a good time. So I highly encourage you, if you haven't already done so, to sign up as a trainee.
And no team is complete without our nurses, and and we have two fantastic nurses who've always supported us for the live cases. We have Rekha here and Denisa. Rekha and Denisa are behind me, and then we have, of course, Damien, who's here. And without our team, it's impossible because we're talking and working, and they're the ones really watching the patient and taking care of everything on the sidelines. So we always appreciate them. And Ramon, I believe, is out there too.
Yeah.
If I'm not sure. Okay, great. So we'll present the case now. Go ahead.
Yeah, and just one more topic before
Sorry.
we present on is just like PK talked about, we have 4 endovascular fellows. So we will be opening our interview season again for next year, starting 2027-28 for a 1-year dedicated endovascular fellowship here at Mount Sinai in collaboration with Dr. Rao in vascular surgery, IR, and vascular medicine. So anybody is interested, you can apply to our program this year. We have 4, so I think it's the largest program in the country. You can email me at my first name dot last name, vishal.kapoor@mountsinai.org, or the program director, maria.directo@mountsinai.org. But the official application season starts very soon. So anybody interested, your colleagues, your fellows, your partners in a dedicated 1-year research, we're happy to entertain the fellowship. Thank you.
Wonderful. So go ahead,
All right.
Vaishnavi.
Yes. Good morning, everyone. Thank you all for being here today.
Yeah, perfect. They'll do it for you.
Okay, our patient is a 80-year-old female with peripheral arterial disease presenting for a staged intervention of the left anterior tibial artery. She has lifestyle-limiting claudication with progression to ischemic rest pain. She has non-healing left lower extremity arterial ulcer, CLTI with Rutherford category 5. She has a past medical history of hypertension, insulin-dependent diabetes mellitus, CKD stage 3, PRE with multiple prior peripheral interventions, most recently, atherectomy and balloon angioplasty of the left posterior tibial artery. We attempted to cross the anterior tibial artery antegrade, but we were unsuccessful. Social history, she's a former smoker, and medications-wise, she's on Aspirin, Plavix, Atorvastatin, Losartan, Metformin, and Insulin. We have the non-invasive vascular diagnostic study. It's a lower extremity arterial duplex. It showed that the distal and proximal anterior tibial artery and posterior tibial artery had monophasic signals. This was prior to the recent intervention.
Okay, so before we get to the discussion on the topic, let's go to the angiogram. And we have Dr. Rao here, so I think it'll be very good. So, Vishal, do you want to describe the?
Yeah, so like we talked about, the patient has significant peripheral arterial disease. Proximally had a stent placed in, but as you can see, the proximal inflow was treated successfully. And distally, you can see a significant disease of the severe peroneal involvement, and the AT is completely occluded. The posterior tibial was the patient moved a lot. The posterior tibial was intervened before and had some flow down there, but in order for complete healing, they also did not heal. And then with Dr. Rao's recommendation and all, and PK, we going after the AT. The AT is completely occluded right at the ostium, pretty much at the proximal end, and the ostium all the way down to the foot, reconstituting pretty much at the DP level.
So she's a little bit more sedated now, so I'm going to take a look at the foot. So to really let you guys know how the foot looks, so you can see the arc. So it's a lateral foot ulcer, Dr. Rao knows. It's towards the, hold on, I can just move this. It's towards the.
But the bar is still going to pull it. Yeah.
It's going to be a lot of pain.
I know.
I'm sorry, my dear. I'm sorry.
That's it.
Relax. So sorry. Sorry. This way. Yes. Thank you.
So PK, lateral ulcer, AT occlusion, because of the calcification and everything.
Yeah. So the question is, is she surgical candidate wise? I mean, what's her EF and all that?
EF is normal.
Her EF is normal, so she is actually a good surgical candidate. She can go. Does she have veins available?
No, I think they did the vein mapping part of it. They didn't have the vein. The patient has known CKD with recurrent episodes, admission with AKI. So I think with review with Ajit, we came to the conclusion to try to give it one more shot of the AT, and if you're not successful, then possibly try to see if we can get a surgical bypass.
Well, the thing here, Ajit, is like you'll see the filling, right? So here's the posterior tibial, right? So as the posterior tibial comes down, see, it goes all the way. Now that was completely occluded.
Correct.
Yeah.
I'm gonna have Vaishnavi go ahead and pull up the last film and show it to you guys. You can see here that posterior tibial was occluded in the foot. And I'll show you a lateral picture. just to show you, we had to balloon angioplasty the lateral plantar artery as well. And let me see here, maybe I'll go a little bit less here. She's in a lot of pain, so it's very hard for us to manipulate the foot. But I'm not going to be able to. She's just moving like crazy. So you can see that last picture, Jet. The posterior tibial artery fills, and it's the lateral ulcer there.
Right.
Correct.
So the idea that you can see the DP comes in at the end.
Yeah, and you see the lateral plantar artery coming in later.
Well, I can't show you in this view. I mean, I think maybe you can scrub out and put that onto the slide, and let's show that picture, please.
Okay.
So I think that's very important for you guys to understand. But go ahead, Jit.
Yeah, no, I think definitely some good teaching points. So like number one, talking about vein. So if they do have vein, the best CLI study, definitely consider that in a patient that can tolerate a bypass. But it's more than that too. It's also anatomy. So here, number one, there's no vein. There's no usable vein. And then number two, to sew to something in the foot, which is basically what we have to do if we're going for that dorsalis pedis AT, graft PTFE just doesn't really work. It goes across the ankle and the durability is very poor. So you almost definitely need like vein or at least a composite. So I don't think, without vein, it's not really a good surgical candidate based on anatomy. And then I think the other good point that you brought up is just angiosomes. So even though there is a, pretty robust PT, the wound is not in that distribution. And so if you can get the AT DP open and get more blood to it, I think that would help. And especially since the wound didn't really improve after the initial angio, after fixing the PT, I think it's totally reasonable to target the DP.
So what we didn't do in that PT, and I'm going to go back to you, and I know that you and I are firm believers in bioresorbable technology, and especially our team here and your team is always believes in that. We just balloon angioplasties and serenaded this and left it. What happened was we were working on the AT for so long. We were going to come back to do this, but we had such a beautiful balloon angioplasty result. But what's your experience been using a spray versus leaving it? I mean, what are your thoughts? I mean, in this kind of lesion, because she'll show you the lesion. It was occluded.
Was it a long CTO or short?
CTO.
Yeah, no, I think it's almost hard to think about it because it's like a shift in how we normally operate. If you see a really good angiogram result, then sometimes you just leave it alone and you wouldn't even consider stenting in the SFA. I think it depends on a lot of things. So number one is the wound. If it's like a small wound that you think can heal in a couple of months, I don't think putting a scaffold there is necessary, because probably just with the POBA it's going to heal, and then even if the intervention recoils a little bit, you're okay. So I use a spree, more if like I need that extra durability. So anyone with rest pain, that the longer the better, basically, because they're going to go back into rest pain presumably, or if they have a large wound, I think then I'm definitely more aggressive about scaffold. But I do think long-term durability, and I'd be curious what you think, but I do think like long-term durability with a drug in the scaffold is probably a little bit better for this spree, if you can even do it, depending on the anatomy.
Yeah. What about you, Vishal?
No, I agree. I mean, the whole idea is, trying to improve the blood flow here, get the scaffold in. I mean, also we have to remember, if it's long CTOs, the amount of scaffolds you use, the durability, the data. I mean, PK was the highest enroller in the BTK trial.
We were, not me.
Yeah, but what I'm headed by you. But what I'm trying to say is the number of scaffold uses also becomes a limiting factor in these cases. If you're doing an AT, we do a atherectomy and everything. Either we do spot stenting or do the whole lesion. That will also determine how much blood flow you want to get down to the leg. So most of the times, like Ajit talked about, if you get good results on PTA with wound healing as the primary goal, then we go for that, and then long-term durability might have to come back and do a touch-up. And at that time, you could do whatever areas of recoil happen, put scaffold up there, and hopefully increase the outcome.
They are coming out with longer scaffolds, so that will help a little bit.
So Karthik, what do you think about the osteum of the AT now? Look at it.
Yeah, I mean, I think you're already past the osteum in a slot. I think it's just getting past that collateral itself, I think, would have been a challenge. I can see it, because it's a blunt stump right there, and I think you already got a little past that. I think you've achieved what you have to achieve. I'm very aggressive. Yeah, I like just like you, but I think bypass is an option. But I think for this, I think bypass has to be reserved, as Ajit said, is what are you trying to achieve? What is the wound size? What is the extent of the wound? What is the stage of the wound? and how much are you trying to see for the durability. If you think that you can heal the wound with 6 months of antegrade flow from the vessel, I think endovascular therapy is a good thing. But if you have an size of the wound which is not going to heal for a year, then I think we have to consider bypass according to best CLI. And rest pain, I think when it comes to stenting, and again, it's what you're trying to achieve. If the patient has rest pain before forming the wound, CLTI, then I think stenting that PT will make sense because of the robustness of the PT, because you want to give them that, even if the wound is healed, you still want to take away the resting pain from the patient.
Well, I don't know. I'll push back. I mean, I don't think the best CLI data is talking about wound size, right?
No,
it does not.
It didn't have that granularity.
Yeah, it didn't have that granularity.
Exactly.
So I think if you have an adequate vein, I think for the audience, I think you really, with the wound, you have to have a discussion with a vascular surgeon regarding, the possibility of a bypass, because, the data clearly shows that autologous saphenous vein within best CLI is superior to endovascular. You can have all the controversial things about best CLI, all that stuff we can talk about separate.
Yeah.
But if you look at the data that's been published, that's the data. And I think the vascular surgery guidelines support that, right?
Yeah, definitely. And then the one other thing I want to mention is also the target. So in this case, it's like a pretty diseased, maybe we're not seeing it well, but
still,
the dorsalis pedis doesn't look that robust. So I don't know if I could even bypass to that, even if that was the only option.
Well, you got to go all the way to the foot. You see where it is.
Right.
You see, there it is. There,
Right
see, there all the way there.
Yeah.
At the ankle. So you're gonna have to really come down. It's really a foot bypass.
Yeah.
So that's the thing. And plus, the posterior tibial was out. So you really would just use the AT as your target to heal. What about this whole topic about the volume of flow and the pressure head with bypass versus endovascular?
I think for me, that's a good point. I think for me, one of the things I really look for, especially with endovascular, is that I have a palpable pulse. I think that kind of, in part, maybe answers a little bit of that question. But if you don't have a palpable pulse, even if you have inline flow, I think sometimes the wound healing is not as good as I want it to be. But if you have like a good pulse, which you almost always get with a bypass because you're going from healthy to healthy, I think that kind of answers that question on its own. But that's what I try to do. After I finish every intervention for a wound, I'm checking if there's a pulse there, unless it's like a perineal that has like a small crow's feet, but they should be palpable in theory.
PK, that's where PAT, the pedal acceleration time came into picture, right? That's exactly what Ajit is trying to say. Is they said, like, if the pedal acceleration time is more than 120, then the wound healing is not as. I mean, the direct correlation is still supposed to be done. I think there is room for doing it.
I would say in practice, though, that's kind of hard. I tried doing that in my office, and it really depends on the ultrasound tech.
Yeah.
Ultrasound tech, yes.
Yeah, if you don't have a good tech or experienced tech, then sometimes that number is arbitrary.
And David, if there are any questions, please chime in.
You want to come in?
Okay, so what we're going to do, I want to show you what we've done so far with Dr. Rao and all of us. We've gotten ultrasound guide. We're not showing it because everybody's doing it. It's really not difficult. Ultrasound guided pedal access. We're able to shove a V18 wire up to this with a loop, because all included, and then we've got access here up top, just proximal to the CTO with a teleport catheter. So now we're going to work from above and below. So let's talk about a little bit of wire choices, guys. So, I mean, what are the choices you're looking at? Let me just do a dry cine. Ready?
Dry cine.
So we're just going to do a dry cine to show you the level of calcification and everything, so you guys can get an idea.
Before you go for wide choices, just wanted to, for the audience purposes, where did you get your pedal access? At what level? And because Ajit is
this was more at the distal. If you see on the ultrasound axis, the distal anterior, there was the non-disease segment on the ultrasound is where we got the sweet spot. The DP had disease, proximal AT had disease. I just wanted more purchase, so I got it right at the ankle, pretty much like the distal AT transitioning into the dorsalis pedis.
And no sheath, right? You just have
sheathless, yeah.
So now this is the calcification, guys. So
wow.
What do you guys think?
Categorize it as a moderate to severe calcification.
Yeah, but I mean, wire choice, when you look at this, I mean, for the audience, what are you guys thinking? David, what would you do?
So I'm sure, just to ask Ajit, this calcification is prohibitive for doing bypasses, implant like the side axis and everything as well?
It's not prohibitive. It makes it more challenging because you have to sew to it, and sometimes the needles have a hard time puncturing, but you can.
Okay.
You can.
All right, so wires, guys. David, why don't you start with you?
Yeah, so with the CTO like this below the knee, I always like to start with a microcatheter and probe with that hydrophilic wire like a command. but we know there's a lot of calcium here. This is kind of almost like a reattempt type of case. I would go up front with the strong tip load wire. My wire of choice would be something from the Asahi line. They have a good line of CTO wires that would be suitable for a pass like this. So that's probably where I would kind of
Need the
start.
penetration wire.
Ajit,
The penetration wire is one of the wires that is pretty good for a case like this.
Yeah, I mean, I agree. I think my go-to is to start with the command because I think it's versatile, but this amount of calcium, I think I'm going to have to upgrade that. So I like the command to start with. I like a V14, V18, especially for the pushability and torqueability. And then I go to an Stato or Confianza after that. Yeah. That's kind of my wire escalation.
So if you want to go define the wire characteristics, Ajit and Vishal, I mean, because I think everybody has different wires, right? We're talking about particular brands. What are the characteristics you're looking for in these wires?
Yeah, so definitely one is like, the gram tip, how heavy a wire it is. So I kind of start low because I think there's a higher chance of perforating, and then I escalate up.
You, Vishal?
Mm-hmm. Yeah, so for me, it's starting with the hydrophilic end of the wire is more important initially because I'm a believer that even though we call it CTOs, there are always micro channels which are accessible in the amount of, not in this case, but generally, yeah. So start with the hydrophilic, try to get as much access as possible. And when you're in the true CTO part of the segment, then I'll switch it to like Ajit talked about, higher tip load wires, which have more pushability and penetration, depending on your liking. You can start, Confianza, you can go Astaros 20, 30, 40 gram tip load. We have the newer wires, like the penetration wire, which PK is using right now. So yeah, exactly. Increasing the gram tip load, and then V18 at the end, if nothing really works, let's switch over to V18, which are the hydrophilic, and loop technique, and then add more pushability as well.
I agree with that, except when I'm going from below, I almost always just start with the V18 for the most part.
Yeah.
Because we have the 018 quick cross, so I do the same thing.
Yeah.
So Karthik, anything different? No.
Yeah, no, exactly as these guys said. I think I would echo that. That's exactly how I normally do it. But I always start with 014 Trailblazer from below. I don't use an 018, especially when calcification is like this, and I'm not sure
you want a V18 or
how the success is going to be and how much I can expand.
You mean
my question to Ajit is, Ajit, how much do you think, like from access standpoint, just for people who are watching the case, is there anywhere you don't want endovascularly accessed? Because it might make it difficult for your bypass?
Yeah, that's a good question. I mean, I definitely wouldn't access the target vessel
Gladius, please,
if you're thinking about bypass. So like, if bypass was an option for this patient, probably we wouldn't do the pedal because that you can get clot, dissect, damage. So anywhere that you think the bypass is going to be sewn to, definitely try to avoid intervening on those areas, accessing it, stenting it, of course.
Give me another torque.
Just can ruin the target.
It's right there, the other torque.
So if this patient was a candidate for bypass, and then we were giving it a shot endovascularly from pedal, you would get a high distal AT access, like that situation?
Yeah, I think you can almost, sometimes we stuck the occluded segment, a little bit higher. And gone retrograde that way, especially with the amount of calcium you have here. It's kind of like a good roadmap for you. So you could do that. But yeah, try to avoid it at all costs because you definitely can affect the target. And that, there's some data that says there's no free interventions. And I think some of that depends on if you're messing up the target.
So for me, the thing here is that, see, you got to break it down into, remember, there's a failed intervention in the past, right? Yeah. So you're going to have a lot of dissection planes, but you still have a lot of calcium. So I think anytime you take a CTO, is you want to go ahead and break the proximal cap, and then you want to have the transition into the distal, right? So when you want to do the transition, it doesn't really matter because unlike the coronaries, on this particular case, you're not really losing any collaterals of any significance in this area. So unless you have a major collateral that's supplying the foot, you can definitely do dissection reentry. You see this, see how this wire is just going? Because we were here before. And the reason we stopped is that we had a lot of difficulty, Ray and I, to actually externalize the wire, and we actually lost the wire once we crossed. So in this area, I think that the issue here is, how are you going to be able to get through and then more importantly, break the wires up into their characteristics. So for me,
Fix
clearly, penetration is one,
Fix it.
torqueability is other, and then of course, dissection, re-entry, as we're going to have to
so
do
you
in
pulled
this
my wire
case, is
back.
going to be very important here.
Mhm.
So, that's the way I think about it, Ajit. I mean, in this
Yeah, no,
case,
yeah, that's great.
So
So,
PK, question for you. Sorry, Ajit, go ahead. Go ahead.
no, go ahead. Go ahead.
No, the question for Ajit, you also is, see, you have a
Keep
robust
going up.
PT,
Okay,
right?
stay there. I'll come back.
And you know
Bring my wire
that
back.
you're
Relax.
using this vessel mainly
Just
for
go
wound
forward
healing.
with this.
So
I
I
want to
mean,
get closer to you.
clearly, no matter,
Okay,
I mean,
now let me
unless
pull
you're
the wire
stenting
back
the
here.
whole
Oops.
vessel, the
Go.
patency
You
of this
need to
vessel
track this up.
is
Yeah,
probably
it's
going
not
to
that
be
far. Hold on.
at
Let
1
me
year
fix
is
the wire.
probably
1
to
second.
the best 50 to 60%. Am I right?
Mhm.
Based on the studies.
Spasmed.
So
Yeah.
so the question is,
Can you
instead
grab me,
of
please?
doing
Thank you.
multiple dissections, would you do a serial dissection and do a cart retrocart to make it easy for you and get a serial dissection? Would be a pattern, or
We won't
would
transfer.
creating multiple dissection planes and getting in would be the way
But
to
but
go, like PK?
but I think it's very funny that you say that as if you can control what you do. You have no control of what you're
Yeah,
doing.
I mean that's
So
what I'm
it's not
saying.
like it's not like you're going to say, "Oh, I don't want to create
I think there's
multiple dissections."
tight
You are going to
lesion
create
right
multiple
there. It won't
dissections. This
cross.
kind of calcium. I don't know. So
Yeah.
to me, I think that it looks it's nice to say that, but I think the practicality is that you got to pull the wire, Michelle.
Yeah, I am.
I'm bending the wire every time I'm pushing this
No,
thing. You really have to pull the wire and keep it taut.
I am.
Yep. So I think that's the key. I think the idea here is the body of this is not mattering. It's the proximal and distal edge that you want to really care about in terms
Is
of
what matters.
entering in the true area that you're going to be able to, externalize and then do your work. Because this area can be stented. That's all I can do.
Yeah, that's
So
what I'm saying.
what is
Hold on.
your
Yeah.
kind of re-entry approach? For me, I like using the
Going
SATO. I
around
think
the
it's almost like a spear, so it finds different planes quite easily.
Hmm.
But you can
Pull your
perforate
catheter back now.
also at the same time. But I like using the STATO, and then
Pull the wire
I've
back.
more recently tried using the Cook re-entry, the BBAC as well.
Yeah.
So that's another option, especially to cross.
Interesting. PK, what do you use?
Look up. I'm underneath you.
Yeah.
I'm
sure,
just
so-
using the Gladius wire. I'm just going to keep pulling Vishal's back because we're in the same plane here.
So
And we're gonna pop
Ajit,
in.
I just balloon. If I think I'm very close, I think pretty much. I don't know if PK does it the same way. I know Vishal is pretty close to what I do, but if I
back.
think like the wires are very close, I just balloon the proximal path and try to use a confianza and just enter in.
I mean,
just
those
make
are
my plane
advanced
bigger.
techniques. I think
Yeah.
you can definitely do it. But I think at this stage here, we're so close as it is.
Yeah.
I think
Right.
we're just going to come down and one
Externalize.
of us is going to cross. So I think
Well,
here
there
I
were
think it's going to
spirals
cross
there.
from above. That's what I really believe.
Would you take another view, PK, to see how far your wires
Always,
are from
Yeah,
each
yeah.
other?
always, yeah.
I think see how we're circling
Right
around
on
the
top of it.
calcium.
Let me just mag it up here. 1 second, Michelle. Let me just come down a little
Yeah,
closer
yeah.
to you.
PK, would you try
Maybe
to
you can take
enter
a
where the
cast-
calcium is minimal, at least, or at least
No,
not
you
circumferential?
know what I do? You know what I've been doing, Karthik, is just come close. See, and I just pull the catheter back. So you see, you're in a different plane. You're going to fall into the right plane. Just come back slowly.
I know.
So you just come back slowly, and then let's see whether we can get in the right plane here. And if we can't, then we'll just keep going another way. That's all.
Probably doing.
Okay, now pull back the catheter. Let's see whether it makes the turn.
I guess
it made the turn there.
And
See,
we're in.
now it may go in. I think it went in. No. Yep, I think it went in.
No.
Maybe
No,
It's
yeah.
right behind you.
Yeah, just
So then
behind.
keep coming. So it'll just fall right in, and and I think that this is the idea that I think is very important for everybody to be patient. This is the area. Like Ray and luckily we did a lot of work last time, but this area it'll fall in somewhere. See how that's moving more freely. So here it should fall in. Let's see, pull back a little bit. Keep coming back. Don't worry, it'll fall.
Do you think you're dissected from above?
Yeah.
Oh, definitely. Because remember, we worked so much on this, and that's what makes it even more challenging.
And this
That's
area.
why we really wanted to do it live here.
Yeah.
And
And look
then-
at the area around the calcium. We're all technically
You
spiraling
think
around
the direction
it.
of that
That's
wire
the-
is okay right there, PK?
It'll change. I mean,
Yeah, it'll change.
I think it's just sort of finding its way, and I
Right.
think you just got to be patient with it. Okay, that's not a good sign right there, but that's okay. Let's see. If not, we'll have to do
Just
some
flip it.
fancy techniques, like you said.
Yeah, you were making progress from below too. So
Yeah, maybe you come from below, Vishal, and then just go from above. Let's see where they cross.
So PK,
Right there. Let's look at that area.
I mean, it's you say it's
That's
fancy,
pretty good
but
right
what
there
I'm
for a
saying
cart.
is, so if you think making a
Let me
like a
follow
balloon
this track
inflation gives
next
you
to
more
it.
space for the wire to fall in instead of like one
Yeah.
single.
Yeah, I mean, you could. I mean, what we can do now is come up
See,
here,
here it goes.
push this catheter up, and then see what. Oh, you got to rail this out for me. It's bending like
Yeah,
crazy.
yeah. Okay, yeah. Oh, you're coming down. Sorry, I didn't see you.
You're pulling the.
Mm-hmm.
Give me a different wire, guys. Give me the new
So
penetration.
normally you follow more traditional methods than at least I know we follow.
Well, I think everybody has different methods for sure, and I think that this is the one. I think now we're going to get even closer. The wires are very close. We'll do another view.
Ajit, what do you do when the wires are not falling into each other? You told me you use a startup to fall in, but if it doesn't,
That's what I did.
Yeah, so first I get frustrated because this can either take 1 minute or it could take 1 hour,
1 hour,
or it just doesn't happen. But
penetration.
so yeah, the stato, and then I think sometimes you need the angle. So I do what PK is doing, which is like I try to find different spots where it might be a little easier to re-enter.
Right.
But if that's not working, then I try to get something with an angle on it, because you guess ultimately you have to poke through it. If that's not working, then I'll try to balloon it as another option.
That's the final way.
But yeah, once you balloon it, though, you really open up that channel, so you kind of commit to it.
Right.
So that's kind of should be towards the end of your algorithm.
Right.
And then I get more aggressive. I mean, I do O and A. If I really think I have a chance of doing it, I might even put in a sheath, so I have a little more support from below. But it's all about escalating. I think that's what you have to figure out if you're starting practice, is what your algorithm's going to be.
I mean, I think in this we should definitely be able to cross. We're so close.
Right.
That I think that I think in this stage I just need to torque around this, guys.
Yeah.
Because the spot where you are in is a good spot to cross. The calcium is not like circumferential.
No.
So it might actually be
open. Give me another
much,
torque.
No, we have
good
torquers,
spot
guys. We have 5 torquers somewhere.
And then
this one.
This is not so much pushability, because you're able to move stuff, but like you can also consider antegrade access too.
If
you're going from above.
I know.
Right.
Yeah.
Ajit, like in general, would you traditionally go up and over all the time, or when you're doing cases like this, you take an antegrade access and a pedal, and then try to do?
I usually go up and over initially, just because that's my routine. But if I'm bringing them back, maybe I couldn't cross it or something, then I consider antegrade if that was an option.
So that you have more support of, especially when you have calcium and everything, you have more support.
Yeah, especially if I can't track things, because it's a straight shot down, and you can sometimes even use like the back end of wires, and it just gives you more options if you go antegrade. And I think with the closure devices,
would you go antegrade or go up and over like traditionally?
Well, in this case, I mean, if the length is not an issue and pushability, I don't think pushability here is an issue.
Right.
So an up and over old-fashioned is fine. If the up and over is acute, or you have a lot of calcium or all the stuff, or that you can't get your device and everything down, then yes, tall person antegrade is great. But
give me an startup.
As you can see here, I think it's more.
What about you, Dr. Gujja?
I mean, for me, honestly, I wait. Let's see.
Yeah.
So I always go up and over. Vishal, I was trained in Sinai, as you know. So I mean, I do exactly like PK does. I always first go up and over. I almost never go antegrade unless it's the only way to do it, or I have any particular reason to.
Let me know. I'll pull my wire. Okay.
So I've rarely encountered that you will have so much pushability issues in general antegrade. I strongly believe pretty much most of the cases can be done up and over.
Yeah, I know.
Yeah. Integrate definitely is a little riskier, but I think there are better closure devices. So I do think it's a little easier to do now.
The radiation is much higher in general. So I mean, we can put a longer sheath and do it. But it's just more inconvenient when you're traditionally doing some things. So PK, wires wise, where are we right now? What wires
well,
are
right now, again, I'm just going in between dissection. Give me a 014 command.
Give me a conference.
Command. And what we're going to do is we're just going to try to get close. I think we're going to cross distally because the loops have been so big in the midsection. Right. So I'm going to try to get distal as possible and then externalize.
Vishal, the wire right where the calcium, you took a medial.
It's the calcium is deflective.
Yeah.
I'm going to try to switch over. Hold on.
Yeah.
You have an 014 from below or 018?
014 from below.
Oh, okay.
And 014 system from below. We can switch it a bit.
Yeah, I think what Ajit is probably saying, probably V18 from below and try. Or
yeah. I'm going to do that. I'm going to try a confianza first. I don't want to start looping it. I mean, that'll create more planes.
I think we've already looped it before.
I mean, but you want to go aggressive.
So I think at this stage, what we're doing is just trying to get close.
Vishal, use your favorite wire, Astardo, 018.
Yeah, I know.
Yeah, we can use that next,
Let me try.
That's Vishal's favorite wire. I know that.
Astardo.
Yeah, it works.
Good wire.
Love the wire.
Let me see where this command is going here.
All right, let's see.
It's tracking the
But
catheter.
I also
Torque
like how you
might
guys
just
are trying to stay away from the origin of the vessel so you don't dissect into the popliteal.
Okay, now pull your catheter back.
Yeah, got it.
And now you're in a reasonable
Oh,
area.
1.8, yes.
Okay, well, give me a torque on this.
So Jit, crossing and everything, because you made multiple dissections like this, I'm using that once we have the balloon inflations and everything. Would you prefer stenting this vessel because of the difficulty you had, or
Yeah.
you still would leave it if you had a good result?
Well, I think when you're dealing with these like deep dissection planes, I think oftentimes POBA just doesn't give you a great result.
Right.
So I would definitely take a picture after I just do a POBA.
Go.
And if it looks decent, then I might try like a serenator or something and maybe spot stenting.
Give me a
Because you
Dakaru,
can't,
guys,
you
here.
know, it's going to take at least 5-6
Give me a torque
scaffolds
on
to get
this
this
one.
whole lesion, so that's not realistic.
Advance this a
Right.
little
That's
For
right.
every
I want
case.
to
Um,
take that plane.
But I think most of the time,
No,
these
no,
cases I end
okay,
up
hold on.
stenting most of it,
Uh-huh.
just because I have to, because there's just, you know, a lot of recoil.
Right.
But the other thing you can consider is serenator or shockwave, you know, especially with all the calcium there.
Calcium.
So those,
Yeah.
yeah.
That's
so
what
I
was
think,
my next question.
yeah, I think how you prep this vessel is also important.
All right, here. I'm going to try to find a different plane from.
Yeah, well, we're gonna have to balloon up top. So I've asked
Correct.
for a this one, a 2.0 Takaru.
Give me a 20 Astado, please.
20, 0.18 or 0.14.
Oh, 20 is always open for.
So would you?
Ajit, sorry, my question, one more question, is
Let's start it.
if you are in a dissection plane, would you still shockwave it?
Good question. I mean, most of the time, no.
Okay.
Unless it's like this
Coming.
circumferential calcium and it's not a bad dissection, but most of the time, no, I'd probably avoid doing it.
PK, would you use a shockwave if you're in a dissection plane?
It just depends on how it is. I mean, for me, yeah, I guess it's case by case basis.
Right.
And then we'll take it from
Floor
there.
PK.
No, I know that it works in SFAs. I mean, if you really want to expand a calcified SFA lesion, I know it does, but I just don't know the mechanism itself, like with shockwave and a dissection plane. I know you have experience, PK, Vishal. What do you guys think? Dissection plane and expansion with the calcium.
It's variable. I mean, listen, it's most of the time it's intra.
You're hitting the wire. See, leave it right there. Let's see. Let me get the balloon down there, and then you can probably cross right there. You have it there?
I don't have it.
I mean, I definitely think you'll get a better result if you're intraluminal.
You didn't
You know,
flush
if you're
it?
actually
I
posing the
flushed
I mean,
calcium.
that's the point,
Yeah.
right? To break the medial
have
and
wire.
adventitial
No,
calcium.
don't move there.
I just don't know when you're in a
just-
dissection plane, would you still have that effect?
Just wait for my balloon to get down there.
Okay, I will.
Just wait, because once
I
you
am.
get down there, you think, well,
Yeah,
Sure,
it's a good question.
I don't want to get here.
I'm not sure there's any data to.
which
Yeah,
which
exactly. I
shockwave
mean,
and dissection
experience.
balloon?
That's all it is, right? That's why I'm
Yeah.
asking you. So it's
Yeah,
It's not going.
is it?
No, I think it's the proximal part that's probably bothering you.
Ray, go.
In this case,
Where's the balloon?
you know, there's some.
Or
I call it
choose
moderate
above.
calcium. I'm not sure I call it severe, so I'm not sure you need lithotripsy here
Yeah,
if your
yeah.
POBAs were
Agreed.
expanding on their own.
Agreed.
Sorry.
I don't think your balloon is still down
Let
there.
me open it
because-
Yeah, we're having a lot of trouble. We're just trying to see whether maybe we move the sheet as we were pushing hard. So many variables that we
Your,
have to worry
your balloon
about.
is right by the stent, I think.
No, sheet
The
is
sheet
sheet is
is-
there.
Sheet is there.
Is that the balloon?
No, no, that's the edge of the stent.
Balloon is where?
Let's see. Oh, we still have a long way. Yeah. So.
Yeah, the distal part of that stent, that's not the balloon.
No, we thought so, but I think that's the.
Pull back and down, up and down.
Yeah, it's not crossing. Maybe we're more distal and we
Here,
can see
yeah.
Yeah, it might be more distal.
Hold on.
Because it really should fly down through that. There it is.
There.
There it is.
There it is.
Go, Ray.
Huh.
No, I think we're through a strut. No, it can't be through a
No,
strut.
we
came
took
through
the
whole
microcal-
Try again.
Yeah.
There you go.
Just the calcium. It's a wire. It's just a wire bias, right?
Okay,
That's all
just
it
go,
is.
Ray.
Yeah.
Keep going, Ray.
And just
Stop
to
there 1
let
second.
the audience know, and you can see it. Like you might feel like the wires are very close.
Go, Ray.
You might think that you might be able to cross, but there are other issues which come up just like this, like wire biases, because you're dealing with long segment CTOs.
Okay.
I think
balloon
what
here?
PK did here is just
Balloon?
be patient. Don't just keep pushing. I think that's the right way to do it. You don't want to push your
Fine.
equipment out, reposition your equipment and everything. Just
Down.
keep assessing where you are.
Yeah.
So I'm just ballooning my track to be able to allow me to go forward a little bit more, go up here.
So, Karthik, do you think there's any role in IVUS right now, or do you think it's not really going to help you?
I think there is always role for IVUS, but I think here
At this
I don't
point,
know
though,
at this point I don't know what we
Okay.
created so many multiple dissection planes. I think
Yeah.
even if you use a serenator or anything, you still have to
Okay.
end up using a scaffold for this vessel.
I think in that, yeah, this is the other challenging part of this case. In the SFA pop,
Now-
you have more options, you know, to re-enter.
Right, exactly.
You know, Outback, Pioneer.
Yeah.
Here, it's
Let me come
really
down there, Vishal.
limited.
I think you're going to cross from below, Vishal. That's
Yeah, that's.
But I think that's where the balloon. I mean, that's why I skip some
try to cross
steps when
into
I
the balloon
do
here.
moderate to severe calcification like this.
I got to pull my
I
wire
just
back.
balloon
Now
it.
you go ahead, try to cross
I
into my
use a
balloon.
cart retrograde. I have very low threshold for
You
it.
go into the balloon, Vishal.
So you
Especially if I'm-
balloon from
Yeah,
above
yeah.
and below?
Come down. Yeah.
Yeah, I
come
just
down.
balloon
Now
from
try to
above
enter the balloon.
and I fall
Above,
from
yeah.
below
No,
in,
but,
just like
yeah, yeah.
Vishal is
Try.
doing now. I just create more space for the wire to fall from below. That's all it is.
Yeah.
I never put a sheath from below. I have almost never put a sheath from below to do the
There you
cases
go.
like this.
No.
No. Mm-hmm. Go to another view.
And I always balloon it at the CTO segment so that if I know that if I have to even,
Hold
I
on, let me try to
don't
come
touch the
down one
proximal
Mhm.
segment at all until I'm sure that I have crossed it. Just like PK is doing now.
Hold on. Okay, Ray. Let's balloon up here. I'm going to pull the balloon back for you, Vishal.
Yeah.
Try here.
I think it's also about finding the right
Mhm.
angle, you know, because
Exactly.
Coming.
right now these
There,
wires
no,
are.
I think it already fell in,
Overlap.
looks like PK.
No,
No.
almost. We're just going to pull back. It'll fall in.
But you're trying to get into the balloon?
Yep.
Oh, wow.
Yeah, why not?
Ambitious.
Let's see.
Why not?
What wire is that from below?
A Stato.
Oh, stop.
Oh, Fishal's favorite.
Yeah. And then very
Listen.
ambitious to get into the balloon through the nose cone. Wow.
All right.
But you
give me the start off. Give me a confianza from above, guys.
PK,
From
what
above.
if you put a
Yeah.
microcatheter there now and fall in, like an overnight microcatheter and fall in?
We
I think
can.
you fell in. Looks
No,
like you did fall in.
Where's your
My catheter is still.
Vishal's
Let me
wire
get
seems
that.
very
Yeah,
free.
hold on.
Is there
Yeah,
any
give me
utility
one.
in taking pictures at this point, or is it better not
I
to?
really don't think so, Ajit, because I think
yeah,
pull,
it's
please,
more
pull
about a
it.
Yeah, I am.
feel.
1 second. Yeah,
Yeah.
pulling now.
It's all
Pulling,
bent.
pulling.
The wires are all bent.
PK, what if you put an
All right,
overnight
change
from
that for an
above?
0-4 wire, and then give an 0-8 to 0-4 teleport. Take this out.
Mm-hmm.
All bent. What's up, brother?
No, I'm saying if you put
I
an,
can take a
I think
new-
Vishal fell in from
Confianza.
below.
Yeah.
What if you put an overnight microcatheter from above and
I think I should take a
and
V18 from below.
externalize your wire?
Yeah, I think V18.
Give me a V18, please.
And then externalize the wire from above itself.
Yeah, are you trying more distally where it's maybe less dissected?
Yeah.
But if that
Right
doesn't
here,
work,
that's where I'm going.
if that doesn't work, then I think maybe V18.
I'm gonna go V18.
Yeah.
Because I think now you're having difficulty moving the microcatheter past that mid calcification, right?
No, it's coming quite easy, Karthik.
No, from below I'm saying.
Okay, give me now a penetration, please. Give me a
Okay.
penetration wire. We have it open, right?
Vishal, your catheter is moving easily from below, or you're having difficulty
No,
pushing the catheter?
it was the
It's all bent,
pushability.
Karthik, because
Yeah.
there was no tension on the catheter. So what else would you do? We could balloon this area here.
Correct.
Let me see. There's a shape on this. Yep, slight shape. Okay, that's all we need.
No, but Vishal, when you Astardo went in, you didn't feel free at the proximal segment?
I was,
It
but
was
those.
too free. It was too free.
Too
Yeah,
free.
he peeked it in.
free.
Yeah. Okay. All right.
Okay.
Yeah,
If not,
thank you.
what we'll
Have
do
your
is we'll
torque.
we'll balloon the proximal cap and try to get
Yeah.
in.
Right.
But I think
Yeah.
that this is the best spot, like Ajit said, try to get in from below. Wow.
How long ago was the other angiogram? Approximately?
About a month ago.
Yeah. So there's probably still some open dissection
Give me a
planes.
torque around this, guys.
Hard to say when they heal.
Yeah.
Vishal, when
thanks,
you, Ajit, when you have proximal SFA disease like this, I mean, of course, I mean, your patency is fine, it's good. When you use a vein graft,
Come on.
an autologous graft for vein, the patency of that vein graft, in your experience,
Mm-hmm.
So yeah, that's a good question. I think one of the things I've learned with doing
Slow down, I'll put
bypasses
it
is
back.
you always want to go from healthy to healthy. Because if you start your bypass, let's say in the SFA and the proximal SFA has a stent in that, your bypass is only going to be as good as that stent. And same with the distal portion. If you sew your bypass to a previous area that you've angioplastied or whatever, again, you're living off the angioplasty. So I always go from healthy to healthy. So, and then especially you're using PTFE, synthetic graft, it doesn't matter because you can get as much length as you need.
Right.
When you're doing vein graft, it's a little, obviously you have
Yes.
to harvest more veins. So that's where
I'm hitting it. I'm hitting it.
where you consider maybe going to the SFA or do something shorter, because it matters more, how much you have to harvest. But in general, in this case, for example, because there are stents there and
Yeah.
it's a little diseased, I'd probably just go from the common femoral for my proximal inflow, especially if it's PTFE. I don't think it'd matter. And that way I don't have to worry about the SFA recoiling or reintervening on that. So it's one less thing to worry about. But,
So let's say you have a great graft. So for this patient, you're going to go from common femoral to the DP, right? You don't think that will affect the patency of the stents because of the steel in the graft and everything?
no, it should be fine.
In the
Should be
native
fine. It's a-
vessel, it should be okay?
Yeah, common femoral is a pretty common, area that we use for bypass, so that should be fine. Like there'll still be plenty of flow going into the profunda. We also, it's going into small vessel distally, so there's really not going to be that much flow that's getting diverted into the
Very nice.
bypass. Yeah.
10.
So yeah, that should be
Now go
okay.
with your wire.
So you're saying the steel is, even the steel from the profunda, when stealing from the graft also, you don't think that's significant? You don't think it will
No,
have?
I haven't
interesting.
really.
Okay, let me
I've only
put
seen
the
that, like when I'm doing a fem-fem,
You don't keep
in like at the donor site, or one of the
Don't want to find.
fem-fem takes too much blood and it actually causes claudication in the donor site, especially if they have distal disease. That's when I've seen
Okay.
steel. That's probably the most common scenario I can think of. But in general, common femoral is totally fine. And sometimes we even go iliac for our bypasses for
Give me
inflow.
a overnight
Wow.
Navicross.
Interesting.
It's now it's
Vishal,
going
it
through.
felt like your wire touched the catheter, no? Didn't?
Yeah, from the.
From below? You didn't touch it?
I'm going up a little bit.
It looks like you're.
I'm coming.
It looks like at least it's very, very close
Oh,
there.
1/8.
It's gonna fall in.
Yeah.
Keep going.
Straight
We
around.
also have like an unfavorable dissection because it's like an AP projection, that you didn't
Right.
need like a full lateral to really maybe see the full extent.
Can you get a torque on this, please?
Yes.
Or it could be that they're very
You want the
close.
straight or
Those are
angled
the two
Navi?
options.
Angle.
Angled.
So Ajit, the length of the stents, how many would you
Here.
How many would
Now
you
it's
say
going to
it's
start going
enough
the other
Here,
way.
keep going. It'll fall.
to Esprit?
The
I mean,
bone is
I know there is no
Hold
there
on,
is
let
no
me get a
limit
torque.
to
It's
Esprit,
not
but
torquing it.
Well, I think how much I'd like to do versus how much I practically can do
exactly, yeah.
are two different questions. But same thing, actually. I think if you believe in the trial and everything and the data, then you really want to scaffold the entire lesion. So in theory, you would
Hold on. We should be able to. Hold on.
scaffold,
There
the
it is. Oh,
No.
entire CTO. That being said, I've had some early
Yep, we
failures.
got it.
Oh, nice.
No,
why'd you
no,
pull
no,
it
no, 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 you're not.
What?
Um,
Go forward. What?
No, it's.
Why? Keep going.
Let's see.
It's good. It's
No.
good. It's good.
No, okay.
No,
that's fine.
no.
Let's come up here.
See?
Now try here.
So close. But in general, I've had some early failures with Esprit, and it usually doesn't happen at the actual scaffold. It happens outside of it. Areas that had recoil outside where I just did a POBA.
Done it the
So
other
in
very
theory,
nice.
I would try to, but there's no
Okay, change this
maximum number. It
support catheter.
really
Take it to
depends on
support
the
catheter. Change this
patient and
catheter.
a whole bunch of
Take this
factors
catheter
Navicross.
on how many scaffolds I'll use in a single
Gonna
case.
Take
Alright, we're
this
gonna-
out.
But
Ready?
easily I'll
Give me
use
the-
2 or
give me the
3,
Navicross.
It's a matter of
Yeah.
how
I
much
have the
more
Navi.
you'll go
That's
after
fine.
that.
That's fine. Leave it where it is.
What about you? Do you have like a cap or how do you decide?
I don't know. I usually feel, I don't have any cap, as you said. Ideally, I would like to stent the whole vessel. I think we are capped by
Is that a
what we
straight or
can
an
do
angle?
Angle.
and what
Give me
we
a
want to
straight.
do.
You want a straight?
I think the maximum I have ever put is 4. That's the maximum I have ever put in any vessel. I think PK has put a little more than that and has more experience. I just don't know the
Yeah, he's
patency
being
of it.
generous and.
Yeah, that's also a good question. I think in the trial, the longer lesions still did
should-
pretty well, but I don't think, we're talking about 7-8
This is
scaffolds.
0 and 8.
Yeah, I just don't know the length,
0.8.
the patency of these stents when you put so many. I don't know what we are trying to achieve. I'm sure it's definitely more than what POBA does, or Serenator does, and everything. But
Well, it's going to be a bigger question because once the longer scaffolds come out, then I think there's going to be longer lesions that are going to get treated because we now have access to that. So then I think
Right.
we'll have to see how they do.
so this much calcium and Esprit,
Rail the wire.
Mm-hmm.
your
Yeah,
experience with it?
As long as so with the Aspirin, I think it's all about vessel prep. You want to get good luminal expansion, so that way you can really maximize your drug delivery. And then there's bench studies to show that too. If you prep the vessel better, you can get a better drug delivery into the vessel. So I think vessel prep is really important.
that.
So, if it was more calcified, maybe shockwave.
Me from above.
I like Serenator a lot too, if I'm combining that with a
Pull your
spree.
back now.
I think that
Right.
balloon prevents a little less recoil, and it's a good prep vessel.
Go with a different one.
So those are probably two of my most common, and then I do atherectomy as well, depending on
Give me a.
the morphology
Let me try
of
with
the
the command
lesion.
first, and then I'll go
But
back
I do
to
think that's
Astato.
very important. You can't go straight in with the spree.
Right.
No, we have the Astato,
David,
right? Give me the
what do
Astato.
you think?
The Astato, you took the Astato.
Yeah, I know, but I want
So,
to.
I think adjunctive therapy is always important, especially in a very calcified lesion
What do you
like
have?
this. Even with long sprees,
Torture?
like the newer
Come on,
sprees that
go
we're
come on.
Would you do a
talking
large?
about.
Do a double balloon now? Put a sheath into a
The
double.
way the
Yeah, I think
mechanism
maybe
that
put in a
the
sheath
sprees
and
are
then
combined is
Can I
not,
give me an Astato,
you know,
it's
Have a torquer?
purely
Yeah,
by
torquer.
mechanical forces.
Give him the torquer.
Sorry.
or try
Right.
near the origin.
Very nice.
You want to just go higher up.
Mm-hmm.
It might pop in through there.
Yeah,
Yeah,
that's what
but-
I'm trying to do.
What do you have? What catheter do you have from below now? You switched it
It's
out?
a Navi Cross.
Oh,
Navicross.
okay.
It's just overnight Navi Cross, just a little bit more.
So it shows the difficulties of these cases. You
Yeah,
have.
exactly. You would think everything will
I think
go.
we have to make a better curve up top.
Ajit, if let's say you have an area where you could not expand as much as you want for the Esprit, have you ever mixed matched Esprit and other DESs?
Pull back your catheter a little bit.
I feel like most people do just for cost purposes, right? Because the coronary stents
What
are
is that over there? It's my-
Yeah,
cheaper.
that's okay.
So that's the most,
Mine is the big one.
when I've heard about it the most. In terms of
Move your wire.
radial
Move your wire.
strength, if
Which
I
wire
remember
is mine
correctly, I think the
up
Spree
at
actually has a
24?
little more radial
Is it
force
going
than
to-
I don't know. I
the
didn't want to
coronary
push it. I didn't
stents
see where
do.
it's going.
So I don't think it actually helps you that
Stay
much.
there?
So I think it's
Mhm.
mostly a
That's a
cost
command. I don't
issue
like the way it
when I've
looks.
seen people do that.
So let's take.
Have you done that, and what's your experience
What?
mixing and
DSA.
matching?
Yeah,
Hold on.
I have done it when I feel
Okay,
like
go.
there's an area where I can't really expand as much as I am supposed to expand, and I feel like Esprit might
What if you
be a
balloon that
problem.
segment?
No, you can
I-
probably pop in. Let's go with your catheter from below.
I usually use a metallic stent
Just
just to
stay
give
there.
me
Hold on.
more
1 second.
strength, radial
It's the
strength. But
command. Okay.
other than that, nothing. If I feel like I put 4 Esprits and I still can't, I still have to get better flow and everything, then I put another DES, just like you said.
Right. What about
Walk the tackle back.
a Serenator? What's your
Don't lose the
algorithm for that? How often are you using specialty balloons?
No, not as much as I would
Yeah.
I would ever
Okay.
use, but I think yes, especially when there's a lot of calcium and everything, I think Serenator does help. I mean, I do shockwave, even if there is a plane. I feel like shockwave has a role if the calcification
Try to walk the.
is
the side.
circumferential. It does have
You
a
wanna
role
balloon
just
that?
to give us more
Oh.
support. But yes, but if I can't use and it's eccentric and everything, then Serenator
Okay, try now
does
from
work
there.
very well.
Go up with a balloon here.
Especially when I do pedals, I have seen they have a pedal Serenator now.
Right? Hold
Yeah.
on.
Oh, they do.
201, yeah, which is
Mhm.
actually crosses
Go
very
up now,
well
right?
into the pedal vessels.
Hold on.
So
Pull
they,
your wire back.
especially when you right at the re-entry point,
Pull
when
your
you
wire back.
want to go in
My wire
or
is
when
back.
you
Oh,
re-enter
catheter?
distally,
Down.
I think it helps a lot. I think that gives a very good result.
Go up here.
I don't know.
Okay.
I have limited experience with it. I think PK Vishal,
Okay.
I think David have a little more experience than I have. What do you guys think, David? Have you used that pedal Serenator?
So honestly, I personally have not used the pedal Serenator, so I can't speak on that experience.
Change
Okay.
the wire, Michelle.
But I think what we
give me
really
a,
need in this space is like a
Astato
DCB. I know obviously there's several trials and
walk
we'll
it
see
out.
what happens, but
Pull your catheter?
for a long lesion like this, rather than scaffolding the entire thing, if we had a DCB that, did better than POBA, that's really what
Yeah.
would matter,
I think we are awaiting that DCB, right? So
Hold on.
yeah,
Give me
for a
one
long
second.
time.
This will
yeah,
go in. One
I
second.
think we will probably have it in PK solution. Is that it?
Yeah.
Yeah, probably in a couple of months.
Torque on this.
Maybe. Yeah.
Hopefully.
PK, you
Not a
I
couple
know
of months. They still haven't finished the
Yeah, the
BTK
November,
trial.
yeah.
So here we're really struggling with this. as
Torque.
we
Did
thought
it?
We would.
Did the wire pop in from below, or
No.
it was stuck in
No,
that
I think it
dissection?
went into a plane.
Hold on.
And you ballooned that area
Yeah, he
too.
ballooned from the top.
Hmm.
Okay.
See, this is where I would probably switch out for V18. I think
Yeah, a
that
little
would poke
bit.
through that septum.
I think I would loop from the top if we can. Hold on.
What wire do you have from below right now?
I have an
And above?
Astaro, but I think you're right. I was just.
Let go now.
Yeah.
Can now try.
Mm-hmm. No, it's too much out.
Vicky,
Lost
you didn't
my curve.
you ballooned it right there, right?
Multiple times.
Yeah. Interesting.
It's hugging the side.
To the side. Is it going free?
No,
I
it
didn't
looks
wanna-
like it's spiraling
Oh,
around
it's
the
on the
vessel wall.
spiraling around it.
Yeah.
Yeah.
Let me try to get this balloon down. Go try to get this balloon down. And then balloon that crossing area where Vishal is crossing. Go.
Let me change the little bit curve on my. Lost my curve.
No, down below, Ray. Go up here. It's fine.
What size balloon is this? A 2?
2-0. Down. No, take it down now. Take it down. And keep going. Keep going. Keep coming. This is where it's not going.
Yeah.
That's where you have to poke. Yeah.
There you go. Okay, let's go here. Balloon on 20. 20 atmospheres. Down.
You want to pull the,
It pushed your catheter out.
you want
Now
to push the
now
catheter
you
back
need to
a little
pull
bit?
the catheter back and re-enter it. Let's see. Now your curve is horrible.
Yeah. Oh, it's lost
Yeah.
my bent the whole thing.
Yeah.
Give me another Astaro, please.
All right, give us a V18. Let's try with the V18 now. Give me now a gladius from above. Okay,
Throw
for the
this
last
garbage.
5 minutes here.
Yeah.
So we're going to keep working.
We'll
V18
fall
from.
in, we'll fall
You want
in.
to be from below? Sure.
We
Yeah, I
got
think this is a time to escalate.
Yeah.
Give me
Yeah.
a
Go all
gladius
the way.
014. We have one in the background. Yes, we do.
But PK, what were you thinking though? If you
I think
cross
it's going
this?
to cross distal. That's what I really believe because
I see.
proximal is just very difficult.
Yeah.
It's just very calcified. I think distal is where it's going to cross, but I think we have to just be patient. Can I have a gladius, please?
Yes,
Let me see. Give me a wire introducer as well.
you have it here.
So, I mean, these are some of the challenges that you face here. I mean, the idea is what else can you possibly do?
So
And, you know,
yeah.
I definitely think here at some point, I mean, we've ballooned, we've done everything. We've crossed once. Unfortunately, equipment malfunction screwed us. But, you know.
So-
Give me another V18.
So the other
Pink.
thing that I do as a kind of last
Wow.
resort is from
Garbage.
above. I'll put in an 035 catheter and glide wire, and just as the last
We
effort,
can
try to
describe.
puncture through the septum that way. Before I abort. But otherwise, mostly 014, 018.
Yeah.
The problem is it's like a big dissection channel. So
Yeah, see, now it's
Yeah.
a huge dissection.
Ajit, I have a question for you. Somebody they asked, what complications should the operators be more concerned, especially when it
I'm
comes
coming.
during the
Vishal.
safari
Yeah.
technique?
yeah, that's a great question. So things that can happen. So if you're in a dissection, obviously perforation. So like I do like to take pictures. I don't think from here we've seen the wire go outside the
Just
vessel,
right
but
there.
if I was concerned, I would be taking pictures just to make sure there's no extrav or anything. From the pedal access site, I mean, the real things that you can do are
Marker on
dissect.
this one.
There's
And-
a 1-4.
That's
So
the V18.
after you're done with your access site, I always like to take a picture from above, make sure the target is still there. And then once I'm, I also do
Dissection.
what they're doing here, which is I only put in an 018 quick cross. So once I'm done, I just pull that out, and usually a couple minutes of pressure will stop that, or I'll balloon tamponade it from above once I cross and everything. But basically, you got to make sure you don't occlude the vessel. That's like the last thing you want to do if that's your outflow in the foot.
Yeah.
So you got to be really careful, and I do think technique matters. So if you're really torquing the catheters and the wires from the pedal access site, I do think you can dissect and disrupt that vessel more. I think if you're going at a gentle angle and being mindful of how much pressure you're putting at the entry site, you're less likely to damage that vessel. And then, of course, I also do I do at least nitro, like a radial cocktail, basically, from the pedal access site once I get access. But it's a good question. I think if
Confianza.
as long as you're not upgrading to like a 5/6 French sheath, it's
That's a con.
pretty unlikely you'll get like a
props
big
are the loop,
hematoma or
but I
anything,
don't
as
wanna
long
do
as
it.
you
There's
do
already so much
the right amount of
dissection
pressure or balloon tamponading. But if you are going 5/6, you definitely gotta put a TR band or make sure you have adequate pressure and hemostasis.
Pull your catheter.
But I do, I do think can be, if
Ray,
done
come
correctly,
here,
it can be a
do
safer
it.
access site in the sense that you're not going to have a life-threatening bleed
You
or
know
anything
what we
like
do,
that
how
that
we
you'd more
walk
likely
back.
get from a groin access site.
Keep
Makes
pulling.
sense.
Yeah.
And then the other thing they talk about is just, how many vessel runoffs. So here we can be a little more aggressive because there is a PT at least going down to the foot. So you're not making the patient ischemic even when you're intervening and doing your intervention. There's still blood flow all the way down.
That's a great point. That's a great point.
So that's always something to consider. I would never do single vessel runoff, pedal access, and a claudication. I just don't think it's worth the risk.
Makes sense.
Oh, too big there. And we're on a huge plane.
Yeah.
Yeah, the plane definitely got a little bigger.
Yeah.
I think this is where you go farther down or try.
Yeah, we're gonna
else.
have to try to get further down here. There you go. I like that, Ray. Nope, I don't like that, Ray. Actually,
You just have to loop it.
The catheter is right on the side of the
Calcium.
the calcium.
Yeah.
Mm-hmm.
You pull it back.
Let's see. Are we hitting the catheter there?
No.
Looks like you are in. Oh,
No.
I wish.
Okay, let's go to another view. This is interesting. We're so close. Look at that.
Yeah.
What's
Right
that?
on top of each other, like right
This looks
side
very
by
close.
side.
Let's balloon here, right? Go up. 1 second, Vishal. Let me just balloon.
I don't want to loop.
So
if I
in
can
general, I
from
think
below.
when you're crossing, multiple angles always helps. If you're not sure if you're
Go
close
to
or
the
not.
1-4 wire from below.
Great point.
And then
Give me a command.
and then
Open
SFA
for
pop
behind.
more often. I like to
I'm
take
in.
pictures.
I crossed.
You're in.
That's
Oh,
it.
nice.
Nice. There you go.
It's just the same thing. It's just constantly working. It's such a pain in the you know what. I hope the audience at home, I mean, sure, you've all been through this, but, you just, Dr. Rao's very critical of us. And he always says, PK, you don't never cross. So it's like one of those
Never
things where we do not want to give up in front of Dr. Rao.
No, I knew you're not going to give up.
No, all jokes aside, I mean, it's just so
What's your
difficult.
Yeah.
So now what we're going to do is I need all of you to do an equipment check, and we're just going to balloon and then we're going to end it there because I'm going to tell you what we're going to do. What we're going to do is we're going to balloon angioplasty. Let me show the wires out.
Yeah,
Wires should be out,
exactly.
right? Yeah, you're out.
Just confirm.
You can just walk out the catheter. And
Okay.
fit
I'm
it.
going to take the catheter
Yep,
out.
I got this in.
All
Pull the catheter.
Pulling.
There's the
Beautiful.
wire.
All right.
You
Yeah,
got the wire?
yeah, 1 second. I need the clip, guys.
Clips and make sure the clips work. So then we'll do a balloon angioplasty and then we'll just tell you what we're going to do. And we'll talk a little bit for about 5 minutes about what destination therapy looks like.
Okay.
Here. So you hold that?
Yeah,
So
I'm
make
going to
sure
hold it.
it's
I
on
am.
it. Pull on
Yeah,
it, please.
yeah,
Make
yeah.
sure because last time when Ray did this, it came off. Okay, now I'm just pulling out the catheter. Okay, give us a 2-0 long balloon. Actually, 2-5 long balloon.
Ajit, Vishal just lost like 6 months of his life.
No.
With the clip stress on. Yes, Vishal. I can see. Vishal is nodding his head.
When he's starting to comment on the
I
bends
know
of the
Vishal
wires,
in and out.
that's it. That means
Well, it's not that. It's just such a hard case.
Yeah.
that
Oh,
Vishal
yeah.
understands.
Good team effort.
Absolutely.
Yeah, yeah.
You do
Good
not
team
want to
effort.
lose this wire. I totally
All
understand.
right,
We're just
so
having fun around.
let's for the
yeah,
audience.
strategy. Next.
And David, I'm curious
David is
your
also
thoughts and-
laughing.
Yeah, guys, I mean, now what is the destination therapy? I'm going to balloon angioplasty here. So, Ajit, let's start with our vascular surgery colleagues.
2.5?
What after balloon
200.
angioplasty? What are you going to do?
Picture.
2.5?
It's a 2.5 200. You asked for a 2.5. You want to taper?
200 is fine.
So I think you gotta get a lay of the land. So after we angioplasty, take a picture. If it all looks ratty and not in a lot of recoil, I'm probably gonna scaffold most of it.
So, do you still? Okay, so let's do that. Karthik, you agree with that?
Yeah, I agree with that, PK. If there is no recoil anywhere, I think scaffolding is the perfect way to do it.
I will
think
use a
distally-
cutting balloon
to
to get because the degree of calcification, I'm sure if you do a regular PT is going to recoil. I would like to cut it and get a little bit more luminal gain, hypothetically, and then see a little bit more wire.
Yeah, you
Don't worry
could try
about
Serenator before
Yeah.
you scaffold. That's
Correct.
another option.
David, Flora.
So in this case, given the long lesion calcium, I
Laura?
would prefer to PTA and then honestly IVL after
That's right, stay right there.
IVF, just to see where we are. But I would like to IVL then
Pull the wire
scaffold.
in.
Okay, got it.
I do
I got it.
expect there to be a lot of recoil, but in this case, scaffold would be my destination therapy.
For me, I none of you guys said it. I'm shocked, especially Dr. Rao. I think I would IVUS. Right?
Oh.
Balloon you
I
IVUS.
said
We
IVUS.
talked
I'm
about
not
it.
sure.
We always said IVUS
I'm
is
not
always.
sure I
we
want to
always
see it
said
on
I-
IVUS.
Yeah.
Yeah,
Wait,
exactly.
fully?
That's what I think. In this
me
case,
both?
I would not want to see that IVUS. So
Because
Okay,
yeah,
here we go.
if it looks good
no,
on
we talked
angio,
about it, PK. We
Actually,
told
get it
like
done. Hold on.
Yeah, get it down. otherwise-
IVUS is always
Hold on,
a
I'm
yes.
going to pull from this side.
So
Come on.
I don't think IVUS is ever a no or anything. I think as Ajit said,
All right, let's
I don't want to see that
Are we out of the
IVUS.
body yet? The balloon out of the body?
No.
No.
not yet.
Flora,
Make
put
sure
your-
it-
Okay, good.
Is that the distal marker or the proximal?
I know. I want to make sure.
That's the distal marker.
But I would definitely IVUS
Approximately.
before.
No, but okay,
Scaffold.
let me ask you this, right? Okay,
Go up. Show me above.
what are we
Ajit, you do
expecting
not
from
have
the
to agree with
IVUS?
PK. You
No, but-
don't have to agree with PK.
Karthik, the question is, what is the information we're
I don't
getting from IVUS? We know we've created a lot of dissection
That's what
plane.
I think. But
Based
I
on
think
the-
PK's point is the recoil of the vessel.
Wow.
To use a serenator, to
Respirate,
use an
breathe.
expensive thing like serenator or
Breathe.
shockwave, I think his point is to use an extra expensive device. Said IVUS will tell
Okay,
us
okay,
if the
Olive, hang
expensive
on.
device is needed or not. Am I
Just
right,
show me
PK?
above. No, look, guys.
I
I mean,
don't
all
know.
jokes aside, I think IVUS is underutilized. I think we all agree. I think
Right.
IVUS gives us a lot of information here, and I think the information I'm looking for is going to be whether I need to debulk the vessel further.
Yeah.
And I know I'm subadventitial, but how subadventitial am I? So I think here you can see the calcium there. The expansion is eccentric. That's going to give me a lot of information there, and it's also going to teach me about the ostium. Hang on, my love. Hang on. Down.
So
And so I think the IVUS is going to be the logical next step in my algorithm. Hold the other side. It doesn't matter.
Yeah.
I'll just pull back.
but that's a good point.
Go up here.
Well,
I'm
I-
all for debulking, but I think the dissection plane here is like so
So extensive.
large potentially that I'd be worried about perforation potentially.
Yeah,
In
the-
exactly.
But I mean, like you said, you won't know until you
IVUS is gonna
IVUS.
tell me whether I'm
Yeah.
going to debulk or not.
Yeah.
And I think IVUS is going to help us. I mean, obviously
Yeah.
she's having pain. She's a diabetic small vessel, but clearly, we are through and through. We crossed. So now we need to just take a look as how can you go to another view and look at the balloon
Yeah.
expansion?
PK, would you
Yeah.
take this balloon down to the level of the stick, exactly where it is to see, because you want to see the flow, right?
yeah,
Not yet. I think that you will get flow here. Yeah, it looks like it's evenly
Right.
expanded.
Correct.
Down. And then I'll go to LAO again.
and my catheter was actually stuck at 7. I think that's where the real lesion is
At
distally. So if you can get a little bit more purchase on the,
You want me to go down further?
yeah,
Okay.
that was the
To
trouble.
where?
To beyond like around 12 or so, 12 or 13,
12,
because that's where it was giving me
Ajit,
trouble with
would
my
you
catheter.
would at
Good.
this point, I know
Perfect. That's good.
what PK
Absolutely.
would do and Vishal would do because we work together, but at
Mhm.
this point, would you take the balloon down and wire into the main
Nice.
vessel, or would you just keep the wire externalized so that you have enough
Down.
support and everything? At what
I-
point would
Now
you
we're
put
gonna
the
take-
wire back into the main vessel?
Yeah, good question. I think it depends on trackability, but I think
Okay, I'm gonna come out.
having the through and through wire is useful.
All right, good.
So I'd probably,
DSA.
in this case, hold
Yes,
off
it is.
and keep the wire external so I have that pushability.
Exactly.
And then once I'm mostly done with my definitive therapy, then put a balloon through the foot and pull the access.
Voila.
Very nice.
Look at that.
That does look pretty good.
It's coming
Well,
behind.
the big role of
guys.
IVUS for
That's the
me
perineal.
is you sizing for the
AT's open.
scaffold.
So now I think IVUS is going to tell me, and I'm gonna do atherectomy. That's me.
Do you want to shoot the proximal too, or?
He's going to do Ajit, why he's going to do
Okay.
atherectomy?
Why?
Because we said no, he's going to do it.
All right, ready? Okay, DSA inject.
But I think Vishal's point is also I think the distal vessel is like almost 3-0 PK.
Look at that.
Wow.
That's the posterior tibial. There's the AT right behind it. You see it?
Yeah.
Yeah.
No, but so the atherectomy is for getting more luminal
So
gain
I think,
and debulking.
So-
I think. What do you think? Ajit?
I would cut
Let's
it.
do IVUS. and we'll argue.
IVUS, well, let's look at the proximal because that's
Oh,
where the
yeah,
loop was
yeah,
the biggest.
Good point. Good point.
But yeah, no, I definitely think directional atherectomy would be reasonable here because it doesn't look like a bad dissection. You
I
just
would-
have to be very careful,
Yeah.
and I also think you have to size it.
PK, why are you debulking again?
To me, you see, look at that. So we have a huge lumen. We have some recoil proximally right there, which I see with my IVUS eyes.
Yeah.
So I think what we do is we
Cutting
go
balloon.
ahead and do an IVUS and then decide. I'm not sold on it yet, but we're just going to do an IVUS. So it's 9:10. So now
Quickly,
I want to close this and then we'll
5 more
stay
minutes,
on
yeah.
live and with everybody. Unless you have time, Karthik, to finish, then we can finish. It's all up to you.
I have time to finish. It's an exciting
Okay.
case. I think
Okay.
it's totally
Fine.
fine. I have nothing to do. So
And Ajit, you're okay with a few more minutes?
Yeah, let's do
Yeah,
it.
I
maximum
think
to
it'll be
9:30.
interesting to see the IVUS.
Well, I lean towards, in this case, especially after doing a 2.5 long balloon PTA and the amount of flow we have, I would probably lean towards, if you want to do any more plaque modification, is do an atherectomy with a cutting balloon. I would go for that part.
Let's take the bets. I bet that the whole vessel is dissected. I don't think debulking has any role. I stand by it. I think atherectomizing this vessel is just inviting more problems. But Ajit, what do you think?
Well, there's all diffuse.
Let's
I think
do
you
the
need-
IVUS.
I think vessel prep matters
Look at this.
because
Yes.
I think we're going to need scaffolds.
Go live on the IVUS, guys.
So whether
Go
you want to
live.
use a
Bring
specialty
down.
balloon atherectomy, I think
Okay.
that's dealer's choice.
Good.
All right.
All right, ready?
You're telling me that this vessel is
Go.
well prepped? Come on. Look at
No,
this
you
thing.
still have a room to prep. I don't know if atherectomy
The
is
mode
way
of
to prep.
prepping is the
Come on,
question.
guys.
Yeah, I think we're talking about mode of prepping.
Mode of prep. We're not talking about
So-
putting scaffolds in.
Vishal wants Serenator.
I want Serenator.
PK Atherectomy.
I would go on
what would you
Serenator
do?
also. Serenator. Serenator.
What do you think, Ajit? You?
I do Atherectomy because I think it'll be
There
more
you
interesting.
go.
Oh, come. It's 2 against 2. It
Two
doesn't
against
break
And
the
also, I want to tie it.
David.
Hey, we still have
So
David.
David,
We still have David.
David, don't say
pressure's on you.
shockwave, man.
So honestly, in a calcified lesion like this, I would prefer Serenator.
All right, give me
Oh,
the
3 against 2.
David
PK loses. There you
It
go.
was a trick question, David.
Oh.
Today, David has become a full attending out of
David,
PK's
David,
shadows.
It was a rhetorical question, David.
So
When I asked David, David said, for once, I will agree with Dr. Guja. You know,
Yeah.
why don't I give him, he looks good with the 3-piece suit. I'll give him today's benefit, you know.
Well, that's funny that you're saying you yourself are looking good with the 3-suit.
I think so. You know, I have to take some way. I have to get him out of your shadow some way, shape, or
That's what
form.
I said.
No, we're laughing. No.
Today,
all jokes aside.
Yeah.
So I think all of the above are there, and I think this really poses the problem.
Mhm.
We don't have an algorithm that says, hey, you know what? In this kind of lesion, you should do this, and this kind of lesion, you should do this. So don't you agree that this is a kind of a problem, that we have a lot of heterogeneity, if I'm saying it right, in our interventional algorithms, Ajit?
yeah, I mean, I think it's also just because the lesions are so diverse. You know, calcium, dissection, size, everything else. But I do think having guidelines would help. But
Or at least algorithms.
But there's not
right,
enough
that
data,
have
you
a little bit of evidence. So again, guys, when you do these kind of tough lesions, see how tough this is? The atherectomy is not even going. Look at this. So what I'm going to do is I'm just going to go ahead and just atherectomize the prox on. I want to get that ostium really good, right? And then I'm going to do one cut. And this was the area we had a lot of recoil, right down 26 on IVUS. So I'm just going to go forward, off. And now I'm going to get a larger balloon. Give me a 2530-210.
So that was the EXL you used?
EXL. What else would you have tried, Ajit?
I would have done the same thing. I think S would be a little too big here.
Yes, it's too big. And the other one is too small, right?
DS would be too small.
Yes, it's
so.
too small. Yeah.
Yeah.
EXL is probably the only one.
So now I'm going to get a 2530-210. This is an aggressive balloon. IVUS sizing. We have our beautiful IVUS team out there. What's the size approximately and distally IVUS?
PK question. I know you used Hawk, but you don't think using a laser or something would give you a more benefit,
385 to 10?
especially when you have calcium and thing like this for atherectomy?
I'm going to ask Ajit, then David. David has a lot of experience with laser. David, what are your thoughts?
So I'm always a fan of laser, and like I said, long segment CTO like this, where we're kind of in and out of the true lumen. I think laser would be a good option. But the thing about laser is that in patients like this, it's going to take a lot of time. So I think taking your time in order to debulk a lesion like this, laser can be very effective.
Okay, that's a great question. Ajit, your thoughts? Anything to add?
Yeah, I think you have options. So I think, directional atherectomy, of course, which we did. I think laser would be another option. I think that would track pretty well here. And then the other option would be orbital, but the outflow, I'd worry about the outflow a little bit in this case. But I think you could use either of those
orbital
options.
in this dissection.
Yeah, I know. With the degree of
that'd be a
depth of dissection.
I mean, they technically
Raised.
so is for directional, but yeah, you're probably right. I'd veer on using directional more so than orbital.
Okay.
But I think laser is fine too.
No,
good.
we're good.
We're good?
Yeah.
Okay.
Very
So
carefully.
Now, guys, so IVUS-wise, it was a 3.5 to 3.8 vessel.
Yeah.
So we're going to go very slow with this because of the calcium. And of course, she's going to have pain. And again, like I said, we have an incredible nursing team.
The distal marker is still very distal or right?
No, we're at like 12 where we ballooned last time.
So, Vishal, I have a question for you. How do you choose between Shockwave and Serenator then? When you're talking about calcium?
Yeah, I mean, Shockwave, if it's long, calcified, I can get any luminal gain after a PTA, then I'll do a Shockwave. If I know like one segment is not opening up whatsoever, even after my aggressive PTA, then I'll do a Shockwave. If in this case, like the vessel did open up or there was compliance in the vessel, so I know the vessel has opened up, but we obviously know PTS, the recoil is so hard. And so with this much calcification, I'll do a cutting balloon to get my cut through the segments of the calcium, decreasing the chances of recoil and increasing the outflow. That's the whole thing. But super tight, non-bailable lesions, we just do shockwave.
I see.
So this is 3-5 at 10 atmospheres down. You can leave it up for 2 minutes there. When Vishal talks, he usually talks for 2 minutes. And so now we're going to go ahead and do the proximal right across. Go ahead.
Get the briefing of the case. That's what it is.
No, it was a great job.
But no, yeah, I mean, again, great thought process.
See, now look at that. Look at 26, how beautifully expanded.
Yeah.
Okay. The atherectomy really works. I mean, listen, I'm a believer. I've been doing.
You talked about atherectomy like I talked about my suit. I'm sorry.
Oh my God! Oh my God!
My Lord!
Oh Lord, Flora. Okay. Now,
look what me and David have to deal with on a daily basis.
After this, guys, I don't think you will place one scaffold if we decide to, and we'll ask everybody. Obviously, we don't have a DCB. So since we don't have a DCB, we're going to have to decide whether things would have changed if we had a DCB or not. Ready?
Nitride verapamil.
So I'm going to just show you the
PK question is.
Okay.
PK question is: if you have to scaffold, how much are you scaffolding? Only where you. How much are you scaffolding here? Only the proximal segment, or you want to come distally?
Well, the data is very, very clear that when you scaffold the whole area ballooned, it's going to do better. So now we have the transitional pass-through pavement. There's one recoil segment there.
Yeah.
I think with the TPT, we're going to place scaffolds from the bottom to the top. So above 10 centimeters above the ankle, we cannot. So that's what's very, very important here. So we're going to go down and make a decision.
Point. Yeah, that's a great point.
So let's make a DSA here. And then we're going to decide, and then we're just going to do the scaffolds offline. I mean, I think everybody look at that. So we don't even need to do that.
Beautiful.
So we can easily go above that collateral all the way
like I said, starting at 12 up, we can actually go up and go from there.
Scaffold offline. The question is, before we go, this is 9:15. I told Ajit 9:30 because he's got a lot of cases. So Ajit, if we have guys get the scaffold sizes 3.0, 3.0, 3.5, and 3.75. Get 3 of each. So Ajit, if you now have an FDA-approved DCB, and it's either Pactax or sirolimus, does that change your algorithm and how you use the scaffold if the data is comparable, equal?
Yeah, so it would, because in this case, I would still scaffold because there's recoil. So I don't think DCB would cut it. But if we had a DCB and it looked really good, I would probably just DCB it.
It looks really good otherwise, right?
Yeah, because
I'll show you scene minus here and on the top of it, Ray. How do I operate this?
But I do think that one area definitely needs a scaffold.
Proximal part. Yeah, right there.
Yeah,
right there you need
around 30.
30.
So you need DCB everything and then scaffold that one area.
Yeah, I think that would be my algorithm if I had it.
What about you?
PK, I would scaffold that whole area. I think the whole area is dissected until almost. I would probably put 3 scaffolds even if I had a DCB.
Really? Okay, that's a great point. Okay, Vishal?
Yeah, DCB with spot stenting.
How about you, David? What do you do? I know you do a lot of these. What do you do?
So DCB, I mean the expansion
3038 times 2, open 2.
The expansion looked great, so I think DCB would be appropriate. But at those entry areas where the proximal cap was, where you had difficulty wiring, I would definitely place a 3 there to kind of just make sure patient.
PK, I never forget what you said about DCB, right? The biggest failure of DCB is the recoil of the vessel, right? Right. That's what the data I think that data is unequivocally clear right now, right?
Well, unfortunately, it's only in the SFA. We've requested Lutonix. We've requested, what's it called, Biolux for their data, so we can do an internal analysis. They have not given it to us. So it would be great to the PIs of the trial to go ahead and request it for the data and then look at the mode of failure. I know that Abbott is actually looking at the mode of failure of angioplasty, which I think will 100% be recoil and intimal hyperplasia. I think mostly recoil in the acute case. So, but I think Karthik, below knee, it's not defined. Above the knee, we defined it at cyanide. Below the knee, it's not.
But I'm pretty sure it will be reasonably the same result, right? And then we have to assume that POBA is not going to give the greatest result unless you have used a modifying balloon or something like that to get the greatest result. And I think that's where IVUS comes into play, like you always
12,
say, right?
15?
IVUS will give you the answer exactly how much to DCB and how much to stent.
Oh, we need the three
Right, that's a good point. But I think in this case, you saw the recoil.
It's
You don't
fell
have a
down.
DCB, and I think we're just going to go ahead and do a scaffold all the way down.
Yeah, I think so.
So we're taking a
Start from
3-0.
15.
It was a 275 vessel distally,
Okay.
and you can see where that collateral came off, Vishal, because that's where you want to
Okay,
the
let
last
me hold on.
angiogram.
Yeah.
And then you can do it. So you can see angiographically normal vessel is that collateral right there. And,
sorry.
and what
Hold
was
on, I'll
that
show you.
collateral number?
Give me one.
So that's where we kind of, and you know that's 10 centimeters above the ankle, right there. Now go off.
Hold on.
Yep. So it looks actually it's below. It's actually, you have to go up
Wow.
to 18, 17. You have to go to
18,
18,
20,
you have to
9,
go
and
to
18. So you want above it, right?
No, but 18 and above.
So we want to go, we don't want to cross the collateral, correct?
No,
Okay, so we go 19, 18, 17 above. Go in.
15, go down. 16.
Yeah, that's a good spot, like right there.
That's right there.
Yeah, right there
Beautiful.
should be good.
Okay.
All right, with that, I know Ajita's cases. We're going to sign off. We're going to go up with this one scaffold. All of you have seen us do scaffolds multiple times. So I don't think we need to go over the steps. Antiplatelet regimen, Ajit, and wound care and follow-up. How often do you see these in your clinic? You're going to see her. How often do you
Yeah.
want to see her? And what are the parameters you look for?
Yeah, I would say roughly
Is there no
about
contact?
every
Oh, there it is.
1 to 2 weeks if it's a bad wound. Every 2 to 3 weeks if it's something small. 2 to 4 weeks for the follow-up for the wound, and then ultrasound would be at the first visit with you, of course, and then every 3 months. And antiplatelets, you could do dual antiplatelet therapy, and then eventually switch to like a low-dose anticoagulant.
Perfect. Karthik, anything different?
Exactly like that. But I'm 1 year now because it's Aspirin, but 1 year
Yeah.
of Plavix, and that's basically what it is.
Perfect.
All right,
Well, with
let's
that,
open the
brother,
next.
I think we're going to sign off. We already did the final shots. David, any final thoughts, parting thoughts?
No, always just want to say that, we're here in the live case chat, so please feel free to answer your questions. We're always here to, answer, teach, and facilitate the discussion with the live cath lab team. So we're always here every month, so we look forward to a lively discussion.
We had a very nice chat today. We had a lot of great questions. I would really encourage, I would echo what David said, is just keep going like that. Please keep asking us
Another trio?
questions. We have the knowledge of Dr. Rao in the room, so I think it'll help.
Too
One more
kind.
three.
So
Yep.
thank you so
All right.
much,
All right.
Dr.
So we're
Rao,
signing
Dr.
off from the
Christian.
cath lab. We'll guys see you later.
Yeah.
Thank you.
So
Thank you,
All right,
everybody.
you guys take care of these freeze.
to sign off, I think it was a great case. As usual, Dr. Christian, Dr. Kapoor, and his team have shown a great result. We look forward to seeing you and hearing from you again. On August 26th is our next live case date. And we really look forward to seeing you in New York, September 24 to 26, to join us for the NYEVS. I think we have amazing faculty coming from all over the world. I think it's with a lot of wisdom they have gained and to use it and to share it with us, especially with, I think Dr. Rao was telling like they're going to show us a lot of cases which they have done. I think it's something to look forward to. So we look forward to seeing you again. And thank you so much for all the support.